Okay. So welcome everyone to the fourth session of the comprehensive neuroanatomy educational course organized by Yemeni Neurosurgical Society in collaboration with the World Federation of Neurosurgery, Young Neurosurgery Forum, and Pakistan Society of Neurosurgeons, along with Neurosurgery Coach and Neurosurgical TV. Today we will have our fourth session, and Professor Riyad Ahmed Raja, Professor of Neurosurgery and President of the Pakistan Society of Neurosurgeons, will be the moderator of today's sessions. So, Professor Riyaz, please, you can take lead from now.
So we have the two topics. One is the anatomy of the occipital lobe. First of all, sorry, because I was just in a panic because my computer was not starting and net was not connecting. So first of all, I will welcome all you and also the presenters, Dr. Yucel and Dr. Hussain. And the topics today are the anatomy of the occipital lobe, sulci gara, and the functional region. And second is the anatomy and applied anatomy of the Sylvian fissure and the insula. So first of all, we invite Dr. Yucel to present on his topic. So Dr. Yucel, please. And Dr. Yucel is the consultant neurosurgeon in Health Sciences University Tepesik Training and Research Hospital in Izmir, Turkey, where our friend Dr. Mehmet Zilali is also there. So we met in Karachi last week, and he's a very regular person and a very innocent, polite person, and always a very good friend of us.
He is in our university. He is our mentor.
Yeah, yes. He's a very nice person, always very kind. Yeah,
we respect him so much.
Yes. So, Dr. Yucel.
Thank you for your kind invitation. Today, I will talk about anatomy of the Sylvian fissure and insula. So, Sylvian fissure is also known as the lateral sulcus, and it is one of our most commonly used surgical routes. That's why it's so important. And it is the most distinct anatomical structure from the lateral surface of the brain. And in the second part of my presentation, we will talk about the anatomy of the insular cortex, which is a hidden structure, and it's also named as Isle of Rail. We will talk about this anatomical structures and anatomical neighborhood of both these important structures. So from historical perspective, the Sylvian fissure, also known as the, like I mentioned, lateral sulcus, it is attributed to Francis Sylvius, and this attribution is actually because of engraving by Ward Camp. When you hear in the lower picture, when he published in 1641 his engraving by he attributed the lateral sulcus to Francis Sylvius. But interestingly, actually, the first real depiction of the Sylvian fissure is attributed to Girolamo de Fabrici in 1600. Also, we should always remember Professor Yaşargil, who was introduced and popularized the Trans-Sylvian approach especially in microneurosurgery and aneurysm surgery. So why Sylvian fissure anatomy is important for us? We use it for vascular lesions, especially for, as I mentioned, aneurysm, almost each kind of aneurysm surgery for the anterior circulation aneurysms and to reach the circle of Willis. There are sometimes arteriovenous malformations around the Sylvian fissure. We use this as a corridor. Also for epilepsy surgery, for selective amygdalohippocampectomy, for insular tumors, paracellular tumors, or even to reach sometimes to anterior portion of the brainstem. We can use the Sylvian fissure as a corridor. That's why its anatomy is very important for us. From developmental perspective, in the human brain, it can be detected until the 13th week of gestation. So here we can see in the 13th week of gestation, this is a three-dimensional of human fetal MRI, and Sylvian fissure can be detected. And we can, in this picture, in the upper image, we can see its development until the 21st week. So Sylvian fissure, also named as lateral sulcus, it is the most consistent landmark on the lateral surface of the brain. It is between the frontal, parietal, and temporal lobes. And it has one stem. Anteriorly, it has one anterior horizontal and anterior ascendant branches. Connection of these branches is also called as the anterior Sylvian point. Anterior Sylvian point as an important landmark for us. It divides to Sylvian fissure into two parts: the anterior portion of it, the sphenoidal segment, and posteriorly operculo-insular segment. Also, these two branches, the anterior ascendant and horizontal branches, divides the inferior frontal gyrus into three parts: the orbital, triangular, and opercular gyri. Posteriorly, it has posterior ascending and posterior horizontal branches, and connection of these also called as the posterior Sylvian point. When we look anterior to the Sylvian point, it travels like an oblique route, and medially it reaches through the chiasma and medial portion of the temporal pole. So in a three-dimensional silicon realistic model, here we can see the medial portion of the Sylvian fissure and its relationships with the uncus and the temporal pole. Also, here now we will see the anterior perforated substance. This is the medial orientation of the Sylvian fissure. In a coronal section, when we look to the Sylvian fissure, it has three clefts. It is a Y-shaped, and when we look to it, it's through the insular cortex, it has two branches. So in this Y-shape, it has an opercular cleft which opens to operculum, and this is the real Sylvian fissure. And superiorly, superior to the insular and inferior to the insular cortex, it has a superior limb of the insular cleft and inferior limb of the insular cleft. From a radiologically, we can see this orientation. I tried to merge these two figures to improve orientation. And this is the opercular cleft, superior and inferior insular clefts of the Sylvian fissure. In Sylvian fissure, as I mentioned, it is the most commonly used, one of the most commonly used surgical routes. And in a cadaveric brain, this is the image of a cadaveric brain from lateral surface, and we see the Sylvian fissure. And superficially, most important structures passes here the branch of the middle cerebral artery and the superior Sylvian veins, also called as the superior middle cerebral veins. These are very important during the splitting the Sylvian fissure not to damage and preserve these structures. So when we look for the arteries, the Sylvian fissure has actually all four compartments of the middle cerebral artery related with the Sylvian fissure. So here we can see a closer up picture, and here more prominent two Sylvian veins, and we can see the middle cerebral arteries traveling inside the Sylvian fissure. This is also, like I mentioned, the cortical branches, M4 branches. When they exit the Sylvian fissure, they are named the M4. Later, we will also focus on other three segments. And here, in a coronal section of cadaveric brain, and the frontal lobes are cut, and as you see here, M1 segment, after the carotid bifurcation, and one segment of the middle cerebral artery is already it gets into the Sylvian fissure. Then around the structure we call the Lyman insula, it gives its bifurcation and gives the M2 branches. Also, here we can see the in this cadaveric specimen is really good. We can see the middle cerebral vein, also known as the deep Sylvian vein. These structures are important during the dissection and opening the Sylvian fissure. So when we look to the inferior surface of the Sylvian fissure, we are looking from top to the inferior. So it is actually we are looking to the temporal lobe. What are these cortical anatomical structures? Here in the left picture, we can see some transverse gyri. These are transverse temporal gyri, and most prominent one is also known as the Heschel's gyrus, which is related of hearing function. So Heschel's gyrus divides the temporal portion of the Sylvian fissure into two parts, the planum polare and planum temporale. In the right picture, we can see, as I showed you in coronal section, the after internal carotid artery bifurcates and one segment goes through the Sylvian fissure, and then it goes its bifurcation and branches M2, and then M3 branches. So these branches also known as the sphenoidal, insular, and opercular segments of the middle cerebral arteries. These are completely inside the Sylvian fissure. So one other important thing about anatomy of this temporal plane is Heschel's gyrus. It's when we follow its trajectory inside the Sylvian fissure, it guides us to the atrium of the lateral ventricle. This is an anterior view of a cadaveric specimen. Here we can see the Heschel's gyrus, and this is planum polare. And the Sylvian fissure is in medial side, the superior gyri. There are some between this shallow sulci called as gyri of Schwalbe. And here is the temporal pole. This is a very unique dissection. It is done by one of my colleagues, Professor Demirtas, and his guides, his mentors are Professor Günger and Professor Ture. We are looking at into the Sylvian fissure from the medial side. So in this cadaveric specimen, as you see here, we are looking from the medial. There is a window, and all the basal ganglia and insular cortex and thalamus are removed. So we can see the medial, we can see from medial viewpoint the Sylvian fissure. So in a closer picture, we can see here frontoparietal opercula, frontoorbital opercula, and temporal opercula. When we specify this gyri, so here is the Sylvian fissure, the surface, and we are in the deep side. We are looking from the same window. These are the suborbital gyri, subtriangular gyri, gyrus, subopercular, subprecentral, and subcentral gyrus. And these are the parietal lobe gyri, the posterior, middle, and anterior transverse parietal gyri. Here the transverse temporal gyrus and planum polare. I want to just show one case just about importance of opening the Sylvian fissure, and it has some good anatomical landmarks. It is a case of Professor Ture. This is an 18-year-old male patient who has this lesion and presented with hemianopsia actually. And the lesion actually, it's a craniopharyngeal mass and compressing the optic nerve. It has, we usually if the lesion in the middle side, sometimes we choose more right-handed surgeons choose the right route, but to preserve the already intact optic pathways in this patient, the left-sided approach is chosen. I should say that the left side of the MRI is left side of the patient. This is the visual field of the patient. And this cadaveric image actually shows us with pterional transsylvian approach, which corridors we can use between the arteries. Classical pterional transsylvian position, 15 degrees head elevated and with rotation to the contralateral side. So dura is opened. So the Sylvian fissure is opening just behind the anterior Sylvian point. Anterior Sylvian point is important portion in dissection of the Sylvian fissure because the space is larger. Here we can see a deep Sylvian vein in this patient. Fenular segment of the middle cerebral artery, and here we can see the tumor. This is the ipsilateral already compressed optic nerve. We are cutting the dural fold to release it to cause more damage, and if it's possible to preserve, or maybe the functions may come back, already lost functions. So I will pass the resection part, and of course the tumor debulging and removing with some fusa or dissection. And here we can see it's anatomical, oh, sorry. The M1 segment of the middle cerebral artery, the carotid artery, and anterior cerebral artery. And with a gentle retraction, all this area can be reached in transsylvian approach. And this big tumor can be removed without damaging other structures of the brain. If you don't open the Sylvian fissure, we should retract. Here you can see the postoperative result as the brain, and the importance of the opening the Sylvian fissure. So my next part of my presentation is about insula. Insula is a hidden cortical structure. It has some functions on sensory processing, emotional regulation, motor control, cognitive functions, and autonomic regulations. And it is like a pyramidal shape structure. It's like reversed weighting standing pyramid. The apex of the pyramid is down and its base is up. And this three-dimensional model shows its some relations of its neighborhood structures, its orientation with the ventricles. Now we will go more deep in its neighborhoods and its sulci and gyri. And here, insula, it's inside the Sylvian fissure. It has 5 gyri. These 5 gyri, 3 of them are short gyri and 2 of them named as long gyri. The short gyri are anterior, middle, and posterior short gyri. Sometimes there are some shallow sulci and there is an accessory gyrus in these. The posterior 2 parts are anterior long and posterior long gyri. And these, the posterior and anterior, the short and long gyri are divided by the central sulcus of the insula. Central sulcus of the insula divides this short and long gyri. There is anteriorly is precentral and anterior sulcus of the insula, and posteriorly postcentral sulcus of the insula. Here, another view of an insular cortex in a cadaveric specimen. Here, the Heschel's gyrus. So, insula, as I see, it has, as you see, 3 short gyri and 2 long gyri. And this is the central sulcus of the insula. So, connection of all the 5 gyri named as the apex of the insula. And beneath it, there is a Lyman insula, which is its connection with the basal portions. Insula has 3 sulci around it. These are anterior, superior, and inferior limiting or anterior perinsular, superior perinsular, and inferior perinsular sulcus. So they have 2 different names in the literature. The connection between anterior and superior perinsular sulci, named as the anterior insular point, and between the superior and inferior connection of these 2 sulci is the posterior insular point. This is an angle of view, and this is the inferior limiting sulcus of the insula, or inferior perinsular sulcus. Radiologically, here we can see also the insular cortex in a brain MRI, and this is A, B, C are the anterior, middle, and posterior short gyri, and here we can see the D and E are the anterior and posterior long gyri. Here you can see the central sulcus of the insula. These are prominent landmarks in the MRI. Also, one important thing about the central sulcus of insula, it's usually corresponds to the central sulcus or Rolandic sulcus. So its arterial supply comes from M2 branches of the middle cerebral artery, and also, as I mentioned, the M2 branch and 2 segment of the middle cerebral artery, also named as the insular segment. So here in a cadaveric brain specimen, we are looking superiorly through the insula. The frontal lobe is removed, and here we can see the insular cortex, M2 segments of the middle cerebral artery, and M3 segments, and closer view of this complex vascular anatomy. And from lateral view, here we can see the short and long gyri of insula and their supplier M2 branches. And this is one of the unique studies by Professor Ture and Yashargil and El-Mefti. So the branches of the M2 branches of the middle cerebral artery, I want to say that especially the central artery, which goes through the central sulcus of the insula, it is the most prominent artery of the insula. And insular cortex is supplied by these branches by the M2 segments of the middle cerebral artery. And here a very close picture of this. This is the central insular sulcus, and this is the central artery, precentral artery, the posterior short gyrus and anterior long gyrus of the insula. And here you can see these branches are supplying insular cortex, its arterial supply. Also, sometimes branches of superior or inferior trunks sometimes directly can send branches to the insula. So in an analysis, actually, about 85 to 90% of the insular supplier arteries from M2 are short, and they supply the insular cortex and sometimes the structure extreme capsule just beneath the insular cortex. About 10% of these arteries are medium-sized, medium length, and they go through the almost claustrum and external capsule. And about 3 to 5% of these arteries can go deep, and they are named long arteries and almost can go to the corona radiata. In the venous anatomy of the insula, they are named like the central insular vein, posterior and anterior insular vein, and these veins drain into the superficial and deep middle cerebral veins. From the cortical perspective, when we go through deep to the insula, here we can see the insular cortex. Also, I labeled with IC here. There is an white matter beneath it. It's called, like I mentioned, extreme capsule. Then a very thin gray matter layer, claustrum, putamen, claustrum, external capsule, putamen, globus pallidus, internal capsule, and thalamus. This is from lateral to medial, deep insular portions. And now we will see them from laterally. I put this image just for orientation. And when we open the Sylvia, when we remove the frontal and temporal operculum and parietal operculum, we can see the insular cortex. So there is a white matter tract which turns beneath, behind the insula. It's called also arcuate fasciculus, and its continuity with superior longitudinal fasciculus. These are the superior and posterior relations of the insular cortex. When we remove the insular cortex, there is an U fibers, a white matter tract, and U fibers. These are the extreme capsule, which has functions about language processing, cortical connectivity, consciousness, and perception, speech articulation. So when we go deeper, there is here is the gray matter, the claustrum, and superior to it, its connection with the cortex, the external capsule. Also, again, deep in the insula, there is another white matter tract which connects the frontal and occipital lobes, also called the inferior fronto-occipital fascicle. And there is an uncinate fascicle, it's anterior to the insular cortex. So in a deeper part, here you can see the external capsule fibers, and in the windows you can see the putamen. A deeper dissection, when we remove completely the external capsule, here is the putamen. Here you can see the anterior commissure, and these are anterior commissure and the structure I mentioned in the previous slide, the inferior fronto-occipital fascicle. These are all joined here to temporal lobe, also named these dense white matter tract, the sagittal stratum. These are all inferior and lateral to the insula. In a deeper part, here we can see the optic radiation fibers with the putamen. And this shows that it's the temporal horn of the lateral ventricle, just for orientation with the insular cortex. And the final stage, after we remove putamen and globus pallidus, the before thalamus, here is the internal capsule fibers, the deepest part of the insula from lateral to medial. This is an axial section. So here we can see the insular cortex and deeper structures, as I mentioned. And these are very important structures which has many functions like consciousness, sensory integration, motor control support, and various other functions. Thank you.
Thank you so much, Dr. Yucel. And the pics were very good. It was very interesting. And that shows also the clips and the live surgery clips. And that was really motivating for the young neurosurgeons and the senior residents.
Thank you very
Thank you
much.
so much.